Good morning all, I'm Camila. We are the 6th group and our group will be dealing with the topic prostaglandins, leukotrienes and platelet activating factor. And I'll be covering the introduction, the biosynthesis, inhibition, degradation as well as the mechanism of action and uses of prostaglandins. The actions and pathophysiological roles will be taken by Parvathy and the remaining portion and conclusion will be completed by Jason. So in this part 1 video, I'll be discussing about the biosynthesis, inhibition and degradation of prostaglandins. So moving on to the introduction, prostaglandins and leukotrienes are the major lipid-derived autocoids. Autocoids means they are self-healing substances and they will actually act like local hormones. Local hormones means they will be released from various tissues and they will produce its effect at the site of release only. Prostaglandins and leukotrienes are biologically active derivatives of 20-carbon atom polyunsaturated essential fatty acids, and these fatty acids are released from cell membrane phospholipids. Moving on to the chemistry, biosynthesis and degradation, chemically prostaglandins are considered to be the derivatives of prostanoic acid, though prostanoic acid does not occur naturally in the body. Coming to the structure, the prostanoic acid is having a 5-membered ring and 2 side chains projecting in opposite directions at right angle to the plane of the ring. And in the coming slide, you can see the structure of prostanoic acid. There are many series of prostaglandins and thromboxanes designated A, B, C, etc. I, depending on the ring structure and the substituents. Each series has members with subscript 1, 2, 3 indicating the number of double bonds in the side chains. It means that the prostaglandins are having different types like PGE2, PGH2, PGI2, etc. So that alphabet will be depending on the ring structure and the substituent, and that number will be indicating the number of double bonds in the side chain of this prostanoic acid. So here you can see the structure of prostanoic acid. It is having a 5-membered ring. 2 side chains in opposite directions are there. A substituent is there, that is COOH, carboxylic group. 2 double bonds you can see here. So this is the structure. Leukotrienes are so named because they were first obtained from leukocytes. So leuko and have 3 conjugated double bonds, that is triene. They have also been similarly designated A, B, C, etc. F and given subscripts 1, 2, 3, 4, etc. It means that just like that of prostaglandins, leukotrienes are also having different types like LTD4, LTB4, LTC4, etc. Prostaglandins, leukotrienes, thromboxanes are all derived from eicosa, tri or tetra or pentanoic acid. Therefore, they are collectively known as eicosanoids. Arachidonic acid is the fatty acid which is released from the membrane lipids in largest quantity which is required for the synthesis of prostaglandins, thromboxanes as well as the leukotrienes. Next, we can look into the biosynthesis of prostaglandins, thromboxanes as well as these leukotrienes. So here you can see that in response to a chemical and mechanical stimuli, the phospholipase A enzyme is getting activated, and this will cause the membrane phospholipid to release the fatty acid, that is the arachidonic acid. And from here onwards, the pathways are starting. There is cyclooxygenase enzyme which is involved in cyclooxygenase pathway or COX pathway. That is the cyclooxygenase enzyme. Then the lipoxygenase enzyme is involved in the LOX pathway or lipoxygenase pathway. So the cyclooxygenase enzyme is responsible for the synthesis of cyclic endoperoxides, and they are PGG2 and PGH2. Then here you can see that the presence of isomerase enzyme is required for the synthesis of PGE2, PGD2 and PGF2 alpha. These are actually the primary prostaglandins. Then the thromboxane synthase enzyme in platelets is responsible for the synthesis of thromboxane A2. But this is a chemically unstable compound, so that it is being converted spontaneously into thromboxane B2 form. Next is the prostacyclin synthase enzyme in the endothelium. It is responsible for the production of PGI2. PGI2 is also known as prostacyclins. So it is also a chemically unstable compound, so that it has been converted into the form of 6-keto PGF1 alpha. So next we can move on to the lipoxygenase pathway. The lipoxygenase enzyme is responsible for the production of leukotrienes. So here you can see the LTA4 is being synthesized by lipoxygenase enzyme. From there you can have this LTB4, LTC4, and from there LTD4, LTE4. That's all. Then this lipoxygenase enzyme is not only involved in the production of leukotrienes, it is also involved in the synthesis of 12-HPETE, which has been converted into 12-HETE. So these are the pathways involved in the synthesis of prostaglandins, leukotrienes, as well as the thromboxanes. So in the coming slide, I'll give more explanation about the synthesis. Prostaglandins and leukotrienes are synthesized locally, and the rate of synthesis is governed by the rate of release of arachidonic acid from membrane lipids in response to appropriate stimuli. These stimuli activates hydrolases, including phospholipase A, through increased intracellular calcium. There are two pathways involved in the synthesis of prostaglandins and leukotrienes. And we can look on to the first pathway. It is the cyclooxygenase pathway or the COX pathway. It generates eicosanoids with a ring structure, and that include prostaglandins, thromboxanes, and prostacyclins. All tissues having COX enzyme can form cyclic endoperoxides, that is PGG2 and PGH2, which are usually unstable compounds. In presence of isomerase enzyme, PGE2 and PGF2 alpha are formed, and they are the primary prostaglandins. Lung and spleen can synthesize the whole range of COX products. Platelets primarily synthesize thromboxane A2, which is chemically unstable, so it spontaneously changes into the form of thromboxane B2. The endothelium generates prostacyclins or PGI2, which is also a chemically unstable compound, so it rapidly converts into 6-keto PGF1 alpha form. This cyclooxygenase enzyme is known to exist in two isoforms, that is COX-1 and COX-2. So let's look into the difference between these two enzymes. COX-1 is a constitutive enzyme in most cells. The level of COX-1 activity is not much changed once the cell is fully grown. On the other hand, COX-2 is normally present in insignificant amounts, and they are inducible by cytokines, growth factors, and other stimuli in the inflammatory response. It is believed that eicosanoids produced by COX-1 participate in physiological functions such as secretion of mucus for protection of gastric mucosa, hemostasis, and maintenance of renal function. COX-2 leads to inflammatory and other pathological changes. However, certain sites in kidney, brain, and fetus express COX-2, which may play physiological role. It means that COX-1 is involved in physiological functions and COX-2 is involved in pathological changes. But at certain sites like kidney, brain, and fetus, this COX-2 will be playing the physiological roles too. The next is the lipoxygenase pathway. This pathway operates mainly in lungs, WBC, and platelets. The leukotrienes generated by 5 LOX are LTB4, LTC4, LTD4. This LTB4 is known as the potent chemotactic. Chemotactic means they are the substances that stimulate the cellular locomotion or migration. This LTC4 and LTD4 will together constitute the slow reacting substance of anaphylaxis, that is SRSA, are released during anaphylaxis. Anaphylaxis means they are severe, potentially life-threatening allergic reactions. So during such allergic reactions, this LTC4 and LTD4, which is being synthesized from 5 LOX, is getting released. A membrane-associated transfer protein called FLAP. FLAP means 5-lipoxygenase activating protein, carry the arachidonic acid to 5 LOX and is essential for the synthesis of leukotrienes. The platelets are having only the 12 LOX enzyme. I've already told you that LOX pathway is not only involved in the synthesis of leukotrienes. So this HPETES produced by LOX can be converted into hypoxylins, trioxylins and lipoxylins. HPETES, they are actually arachidonic acid 5-hydroperoxides, and this hypoxylin are set of epoxy alcohol metabolite of polyunsaturated fatty acid. That is, they possess both epoxide and an alcohol residue. These promote the inflammatory response of human tissues like mucosa surface, besides the skin, etc. And the trioxylins and lipoxylins, they are actually anti-inflammatory, anti-proliferative, and pro-resolving molecules, and they are very essential in maintaining the tissue homeostasis. There is also a third enzymatic pathway involving the cytochrome P450 enzyme, which can metabolize the arachidonic acid into 19 and 20 HETES and epoxy eicosanoic acid. This HETES are eicosanoids and they are the metabolite of arachidonic acid, and its expansion is 5-hydroxy-eicosanoic acid. Actually, they are involved in host immune defense mechanism. And epoxy-eicosanoic acid, they are actually these signaling molecules and they are involved in the regulation of blood pressure as well as the kidneys' regulation of salt and water absorption. So next is the inhibition of synthesis. That is, the synthesis of COX products is inhibited by NSAIDs. NSAIDs means non-steroidal anti-inflammatory drugs. And aspirin. Aspirin is a drug which comes under the category of NSAIDs. Most NSAIDs are non-selective COX-1 and COX-2 inhibitors, but the celecoxib and etoricoxib are selective for COX-2 enzyme. The glucocorticoids inhibit the release of arachidonic acid from membrane lipids so that the synthesis will not occur. Moving on to the degradation. The biotransformation of arachidonates occurs rapidly in most tissues, but fastest in lungs. It means that the metabolism will be happening in the fastest rate in the lungs. Most prostaglandins, thromboxanes, and prostacyclins are having plasma T-half of a few seconds to a few minutes. First, a specific carrier-mediated uptake into cells occurs. Then the side chains are oxidized and the double bonds are reduced in a stepwise manner to yield the inactive metabolites. So this is how the metabolism takes place. And these metabolites are excreted in urine. The PGI2 or prostacyclin is catabolized mainly in the kidney. So these are all about biosynthesis, inhibition and degradation. I hope you are all clear with it. Next, we can look into a small classification of prostaglandins. The prostaglandins has been classified into two categories, that is natural prostaglandins and prostaglandin analogs. The natural prostaglandins include dinoproston, gimiprost, dinoprost, alprostadil and prostacyclin. This prostacyclin is also known as epoprostenol. Then the prostaglandin analogs include carboprost, misoprostol, latanoprost, travoprost and bimatoprost. So this is the classification of prostaglandins. So this is the end of part 1 video and wait for part 2. Thank you. Welcome all to the part 2 video, and in this video we will be discussing about the prostaglandin receptors and the mechanism of action of prostaglandins. So this is a figure representing the mechanism of action of prostaglandins. But first I will explain you about the mechanism of action, and again I will come back to the figure. Prostaglandins, thromboxanes and prostacyclins act on their specific receptors located on cell membrane. 5 families of prostaglandin receptors are present, and they are DP prostaglandin receptors, EP receptor, FP receptor, IP receptor, and TP receptor. So these are the 5 families of prostaglandin receptors. All these receptors are G protein coupled receptors, which can be functionally categorized into excitatory or contractile, relaxant, and inhibitory groups. It means that these prostaglandin receptors are again categorized into 3 types, that is contractile group, relaxant group, and inhibitory group. So the contractile group that include EP1 receptor, FP receptor, and TP receptor couples primarily with GQ protein and activate the phospholipase C beta to generate IP3 and DAG. These second messengers release the calcium intracellularly, resulting in excitatory responses like smooth muscle contractions and platelet aggregation. The relaxant group, which include DP1 receptor, EP2 receptor, EP4 receptor, and IP receptor, couples with GS protein, which activate the adenylyl cyclase to generate the intracellular second messenger, that is CAMP, resulting in smooth muscle relaxation, inhibition of platelet aggregation, etc. through CAMP-dependent protein kinase. And the inhibitory receptor, that is the EP3 receptor, will couple with the GI protein and inhibits the adenylyl cyclase and exerts anti-lipolytic action. The inhibitory receptors are just opposite to that of the relaxant group. The relaxant group is just activating the adenylyl cyclase pathway, but this inhibitory group is inhibiting the adenylyl cyclase pathway. So let's look on to the figure. So this is the figure, and here you can see that the primary agonist, that can be the PGE2, PGF2 alpha, and thromboxane A2, which is binding to the receptor like EP1, FP, and TP, will couples with the GQ protein, and the thromboxane A2 is also coupling with the G16 protein. And this will activate the primary signaling pathway, that is phospholipase C beta, so that the PIP2 gets transformed into IP3 and DAG. So this IP3 and DAG are the secondary messengers which will cause the release of calcium intracellularly. So this will result in the response like smooth muscle contraction and platelet aggregation. So this is the contractile group. Next is the relaxant group, which include the primary agonists like PGD2, PGE2, and PGI2. It will couples the GS protein. How? When this primary agonist is binding to the receptors like DP1 receptor, EP2 receptor, EP4 receptor, and IP receptor. So this coupling will result in the activation of adenylyl cyclase. And this will result in the conversion of ATP into CAMP. So this second messenger, CAMP, will cause the responses like smooth muscle relaxation, inhibition of platelet aggregation, and intestinal mucosal secretion through protein kinase pathway. And the last one is the inhibitory group, so that the primary agonist like PGE2 is binding to the receptor EP3. Here you can see that receptor. So the binding of primary agonist like PGE2 to EP3 receptor causes the coupling with GI protein, and this will result in the inhibition of adenylyl cyclase, so that the conversion of ATP into CAMP is blocked. So there will be no activation of protein kinase. And the response produced by these inhibitory groups are the inhibition of lipolysis, that is the anti-lipolytic action. So this is the mechanism of action of prostaglandins. The three types of PG receptors, that is contractile PG receptors, relaxant PG receptors, and inhibitory PG receptors. All these are producing different responses through different primary signaling pathways. So you can go more deeper into this figure, so you'll be getting more idea. Next, we can move on to the receptor types. So first one is the DP receptor. The DP receptor, it has strong affinity for PGD that PGE2 can also activate. There are two subtypes for DP receptor, that is DP1 and DP2. DP1, that is a relaxin receptor which dilates certain blood vessels and inhibits platelet aggregation. The DP2, that receptor will couples with the GI protein and inhibits the CAM generation. Next is the EP receptor. It is having high affinity for PGE2, and N-prostyl is a selective agonist of EP receptor. There are four subtypes for EP receptor, which include EP1, EP2, EP3, and EP4. EP1 is a contractile receptor, and it will contract the visceral smooth muscle. EP2 and EP4, they are relaxant in nature, and they act by increasing the CAMP in smooth muscle, but the same second messenger enhances the chloride and water secretion by intestinal mucosa. EP2 is present in few organs, and EP4 has wide distribution in the body. EP3 receptor is inhibitory and decreases the CAMP generation by coupling with GI protein. The anti-lipolytic action of PGE2 is exerted by opposing the CAM generation in adipose tissue, and the distribution of EP3 receptor in the body is wide. Next is the FP receptor. This contractile receptor is highly expressed in the female genital tract and is present in many other organs also. It exhibits strong affinity for PGF2 alpha, and fluprostanol is a selective agonist of FP receptor. Next is the IP receptor. This receptor is relaxant in nature, and it is having strong affinity for PGI2, but PGE2 also acts on it. Cicaprost is a selective agonist, and it is expressed in heart, lungs, kidney, platelet, and in platelet it is having anti-aggregatory action, but the highest density is in the vasculature. Next is the TP receptor. The TP receptor is having high affinity for thromboxane A2, and this contractile receptor is abundant in platelets, and it is having aggregatory action, and it is also present in cardiovascular system, immune cells, and many other organs. PGH2 can also activate this TP receptor. The TP receptor functions by activating the phospholipase C-beta through GQ and G16 proteins, apart from the IP3-DAG calcium phosphokinase pathway. So these are the different types of prostanoid receptors. And here is a small box. It is actually the summary of prostanoid receptors, its subclassification, the receptor location, and the coupling proteins, along with the pharmacological effects of prostaglandins. So I hope this will help you more. So this is the end of part 2 video, and wait for part 3. Thank you. So welcome all to the part 3 video, and in this video we'll be discussing about the uses of prostaglandins. The clinical application of prostaglandins and their analogues are restricted due to its limited availability, short-lasting action, cost and frequent side effects. However, their use in glaucoma and obstetrics are in commonplace. So the first use of prostaglandin is abortion. The prostaglandins can be used for the first trimester as well as the second trimester termination of pregnancy. During first trimester, the termination of pregnancy by transcervical suction is the procedure of choice. The intravaginal PGE2 pessary inserted 3 hours before attempting dilation can minimize the trauma to the cervix by reducing the resistance to dilation. The medical termination of pregnancy up to 7 weeks is achieved with administration of mifepristone, which is an antiprogestin drug, 600 mg orally 2 days before a single oral dose of misoprostol, 400 microgram. This is an alternative to suction evacuation. The uterine contractions are provoked and the conceptus is expelled within the next few hours. The intravaginal misoprostol is now favored, but the sublingual route is also advocated. Uterine cramps, vaginal bleeding, nausea, vomiting, and diarrhea are the common side effects. Methotrexate, administered along with misoprostol, is also highly successful for inducing abortion in the first few weeks of pregnancy. The prostaglandins have a place in midterm abortion, missed abortion, and molar gestation. The prostaglandins will convert the oxytocin-resistant midterm uterus to oxytocin-responsive one. And for this, we can use a single extra-amniotic injection of prostaglandin E2 followed by IV infusion of oxytocin, or an intra-amniotic PGF2 alpha with hypertonic solution produces the second trimester abortion, and the pre-treatment with mifepristone improves the efficiency of prostaglandin E2 as abortifacient. The next use is induction or augmentation of labor. The prostaglandin E2 and PGF2 alpha are used in place of oxytocin in toxemic and renal failure patients as they do not cause fluid retention. And the PGE2 may be used to augment the labor if it is slow, particularly in primipara. Primipara means it is a condition in which the woman is giving birth for the first time. The intravaginal route is preferred now, but the extra or intra-amniotic route are also infrequently used. The third use is cervical priming or ripening. Applied intravaginally or in the cervical canal, the low doses of PGE2, which do not affect the uterine motility, make the cervix soft and compliant, and good results are with unfavorable cervix. If needed, the labor may be induced 12 hours later with oxytocin. The fourth use is postpartum hemorrhage, that is PPH. The carboprost injected intramuscularly is an alternative drug for control of PPH due to uterine atony, especially in patients who are unresponsive to ergometrine and oxytocin. The next use is glaucoma. Topical PGF2 alpha analogs like latanoprost, travoprost, bimatoprost that are the FP receptor agonist are the first choice drugs in wide-angle glaucoma. The next use is peptic ulcer. The stable analog of PGE2, that is misoprostol, is occasionally used for healing peptic ulcer, especially in patients who need NSAID therapy. Next is to maintain the patency of ductus arteriosus. Actually, this patent ductus arteriosus, that is PDA, is an opening between two blood vessels leading from the heart. And it is in the neonates with congenital heart defects till corrective surgery is undertaken, we'll be using alprostadil to treat or maintain the patency of ductus arteriosus, but apnoea can occur in few cases. The next use is to avoid the platelet damage. PGI2 or ipoprostenol can be used to prevent the platelet aggregation and damage during hemodialysis or cardiopulmonary bypass. It improves the harvest of platelets for the transfusion. Means that during the procedures like hemodialysis or cardiopulmonary bypass surgeries, we'll be administering the ipoprostenol to prevent the platelet aggregation. The next use is pulmonary hypertension. The prostaglandin I2 lowers the pulmonary artery resistance, and few cases of primary pulmonary hypertension have been successfully maintained on ipoprostenol infused continuously in a large vein. Next use is peripheral vascular diseases, that is PGI2 or PGE1 infused IV can relieve the rest pain and promote healing of ischemic ulcers in severe cases of intermittent claudication and in Raynaud's disease. And the last use is impotence. The alprostadil injected IV into the penis can cause erection lasting 1 to 2 hours. Oral sildenafil or tadalafil is now preferred for erectile dysfunction. So these all are the uses of prostaglandins. I hope you all understood everything clearly. So this is the end of the video. Thank you all for listening me. Thank you.
Hi everyone, I'm Parvathy from 2nd PharmD. I'll be dealing with the actions and pathophysiological roles. So, prostaglandins, thromboxane and prostacyclin, PG, TX and PGI. The cyclic eicosanoids, they can produce a wide variety of action depending upon the particular prostaglandin or thromboxane or prostacyclin. As said in the introduction part, prostaglandins are of different types like prostaglandin E2, PGF2 alpha, PGI2, etc. And depending upon the type of the prostaglandin, their actions may vary. Then it may depend on the species on which it need to be tested, the tissue, the hormonal status and other factors. Prostaglandins differ in their potency to produce a given action, and different prostaglandins sometimes show opposite effect. Starting with their roles and actions on CVS, prostaglandin E2, PGE2, termed as dinoprostone, cause vasodilatory action in most but not in all vascular beds. So vascular bed is a network of minute blood vessels, and PGE2 can cause vasodilation in most but not in all. PGF2 alpha, that is prostaglandin F2 alpha, termed as a carboprost, can constrict larger vein including the pulmonary vein as well as can constrict arteries. When prostaglandin E2 injected intravenously, they can decrease the blood pressure. But prostaglandin F2 alpha has only a very less effect on BP, because prostaglandin E2 has the ability to dilate blood vessel, thereby decreasing the blood pressure. Prostaglandin I2 uniformly causes vasodilatory action and is more potent hypotensive than prostaglandin E2. Thromboxane A2 produce vasoconstriction. Prostaglandin E2 and F2 alpha, as said earlier, prostaglandin E2 has the ability to decrease BP. So they can stimulate heart more by the reflex action occurs due to the reduction in blood pressure. And cardiac output increases. Roles: prostaglandins do not circulate in blood. So they do not have any kind of role in regulating the systemic vascular resistance. Prostaglandin I2 generated in the vascular endothelium by COX-2, that is cyclooxygenase 2, is involved in the regulation of local vascular tone as dilator. Prostaglandins generated by COX-2 along with leukotrienes and other autocoids can mediate vasodilation and exudation at the site of inflammation. Prostaglandin E2 is continuously produced by the COX-2 during the time of fetal life and it is kept at patent. And at the time of birth, the synthesis stops and closure occurs. Moving on to the actions in platelets, thromboxane E2 produced by the platelets is a potent inducer of aggregation and release reaction, while prostaglandin I2 is produced by the vascular endothelium is a potent inhibitor. Prostaglandin E2 has dose-dependent pro- and anti-aggregatory action. That is, thromboxane A2 will induce aggregation and prostaglandin I2 will inhibit the platelet aggregation. Roles: thromboxane E2 produced by the platelets and prostaglandin I2 produced by the vascular endothelium will constitute an antagonistic system. That is, one will induce aggregation and the other will inhibit aggregation. So they mutually will constitute an antagonistic system. So they can prevent aggregation of platelets in circulation and induce aggregation whenever plugging or thrombus is needed. A note: aspirin can interfere with hemostasis by inhibiting platelet aggregation. At low doses, they selectively inhibit thromboxane A2 production and has antithrombic effect that lasts for more than 3 days. Next is uterus. Prostaglandin E2 and prostaglandin F2 alpha can consistently contract human uterus both in pregnant and in non-pregnant. During the early stages of pregnancy, uterine is quite sensitive to prostaglandins, though not to oxytocin. Prostaglandins can increase the basal tone as well as amplitude of uterine contractions. That is, prostaglandin can control the intrauterine pressure occurring between the contractions. At low doses, the prostaglandins can soften the cervix. Roles: fetal tissue can produce prostaglandin. At term, prostaglandin F2 alpha is detected in maternal blood. Prostaglandins can mediate initiation as well as progression of labor. And increased synthesis of prostaglandin by the endometrium can lead to dysmenorrhea in women, that is menstrual cramps. Note: aspirin is found to delay the initiation of labor and prolong its duration, as well as similar category of drugs like aspirin are highly effective in delivering dysmenorrhea in women. Next is in bronchial muscles. Prostaglandin F2 alpha, prostaglandin D2 and thromboxane A2 are potent bronchoconstrictors, while prostaglandin E2 and I2 cause bronchodilatory action. That is, PGE2 is a powerful bronchodilator and PGI2 causes mild dilation. So these two can inhibit the histamine release and are effective by aerosol. The antihistaminic effect of PGE2 and PGI2 cannot be exploited because they produce irritation of the respiratory tract and have a brief action. Role: asthma is due to an imbalance between constrictor prostaglandins along with cysteinyl leukotrienes and dilatory prostaglandins, that is F2 alpha, prostaglandin D2 and thromboxane A2 have a bronchoconstrictory action, and prostaglandin E2 and I2 have a dilatory action. So an imbalance between the constrictor prostaglandin and the dilator prostaglandin result in asthma. In some individual, aspirin-like drug, they can induce asthma by diverting arachidonic acid to produce excess of leukotriene C4 and leukotriene D4. In GIT, longitudinal muscles of GIT is contracted by prostaglandin E2 and prostaglandin F2 alpha. Circular muscle can either be contracted or by relaxed. By PG F2 alpha, the circular muscles are contracted, and by PGE2 they are relaxed. Propulsive activity is enhanced in man, especially by prostaglandin E2. So colic, diarrhea and watery diarrhea are the important side effects. Roles. Prostaglandins may be involved in mediating toxin-induced increased fluid movement in secretory diarrheas. Prostaglandins play an important role in the growth of colonic polyp and cancer. Prostaglandin E2 marked by reduced acid secretion in the stomach. Also, volume of juice and pepsin content is decreased. Release of gastrin is also suppressed. Usually, gastric pH is acidic, having a range of 1.5 to 3.5. Due to a marked reduction in the acid secretion, the pH may rise up to 7, which is a neutral pH. Secretion of mucus and bicarbonate by gastric mucosal epithelial cell is also increased. Thus, prostaglandins are anti-ulcerogenic. Prostaglandins, especially prostaglandin I2, is involved in the regulation of gastric mucosal blood flow. They may function as natural ulcer protective by increasing the gastric mucus and bicarbonate production, as well as improve the mucosal circulation and health. Coming to kidney, prostaglandin E2 and prostaglandin I2 can increase the water, sodium and potassium excretion and have a diuretic effect. Prostaglandin E2 has inhibitory effect on chlorine reabsorption. Similarly, it can cause vasodilation, can inhibit the tubular reabsorption, attenuate ADH action, thereby increasing the diuretic effect. Thromboxane A2 causes renal vasoconstriction. So roles. Prostaglandin E2 and prostaglandin I2 produced by cyclooxygenase 2 in the kidney appear to function as intrarenal regulator of blood flow as well as tubular reabsorption. So the COX-2 inhibitors, they tend to retain the salt and water. Renin release in response to sympathetic stimulation, low salt intake and other influences may be facilitated by prostaglandins. Next is their action on CNS. Prostaglandins, when they are injected intravenously, they do not have any prominent central action because of their poor brain penetration. But when they are injected intracerebroventricularly, PGE2 can produce effect like sedation, rigidity, increased body temperature, etc. Prostaglandin I2 can produce fever while thromboxane A2 is non-pyrogenic. They do not cause any fever. Roles. Prostaglandin E2 may mediate pyrogen-induced fever and malaise. Pyrogens, including the cytokines, released during bacterial infection can trigger the synthesis of prostaglandin E2 in the hypothalamus, thereby reset the thermostat and produce fever. Prostaglandin may be functioning as neuromodulator in the brain by regulating neuronal excitability. They also play a role in pain perception, sleep, and other functions. In sympathetic nerves, depending upon the type of prostaglandin, species and tissue, both inhibition as well as augmentation of Na released from the sympathetic nerve ending is observed. However, prostaglandin E2 will inhibit the release of noradrenaline. Role. Prostaglandins may modulate sympathetic neurotransmission in the periphery. In peripheral nerves, prostaglandins, especially prostaglandin E2 and prostaglandin I2, can sensitize afferent nerve endings to pain-inducing chemical and mechanical stimulus. They can cause irritation in the mucous membrane and will produce a long-lasting pain of intradermal injection. Roles. Prostaglandins can cause pain during inflammation. They cause tenderness and can amplify the action of another analgesics. Prostaglandins released in the dorsal horn of spinal cord, that is the posterior gray column, by painful stimuli will sensitize the neuron to pain perception. This figure, it shows the prostaglandins sensitize afferent nerve endings to pain-inducing chemical and mechanical stimuli. Next is their action on eye. Prostaglandin F2 alpha will induce ocular inflammation and can lower the intraocular tension by enhancing uveoscleral and trabecular outflow. Roles: locally produced prostaglandin seems to facilitate the aqueous humor drainage. Deficiency of COX-2 in ciliary body in wide-angle glaucoma patient supports this. On endocrine system, prostaglandin E2 will facilitate the release of anterior pituitary hormones. Then will facilitate the release of insulin and adrenal steroids. They have TSH-like activity on thyroid. Metabolism: prostaglandin E are anti-lipolytic, that is, they can counter the lipolysis. They exert insulin-like effect on carbohydrate metabolism and mobile calcium from bone. They may facilitate hypercalcemia due to bone metastasis. So that's all about the roles and actions. Thank you.